Good afternoon, and welcome to this webinar. I'm Daniel Dajani from Jopaigo, Ethiopia, and Health Workforce Improvement Program. Today, I will be co-facilitating this wonderful webinar and supporting Julia. As you know, EMA is conducting a series of webinars. Today, we'll have a 90 minutes webinar session. It's going to be, have, interactive presentation, question and answer, discussion, and also inbuilt reflection session, so that you have opportunity to reflect on the webinar. The title of the webinar is Evidence-Based Learning and Performance Improvement Approach for Building the Capacity of Health Professionals. This is actually the findings and synthesis report of situational analysis, multi-country situational analysis. It has this webinar has like any other webinars of EMA, it has the knowledge check at the end. It has a 5 MCQ questions you have to fill that. And again, like any other where EMA is undertaking, it has CPD credit hours of 1.5. So in order to gain that CPD credit hour, you have to fully attend this webinar, and then you have to complete the assessment and make sure that's submitted to the EMA. Today the session will be facilitated by guest speaker Julia Bluestone. She is Jopaigo, our Jopaigo colleague. She based at Baltimore office, headquarters of Jopaigo in the US. She is a senior technical advisor and team lead for health workforce activities. She is actually backstopping multiple country offices. She is also, behind the screen supporting Ethiopian, health workforce activities conducted by Jopaigo. And I can say she is a long-time friend of Ethiopia, supporting our health system. Thank you, Julia, for that. She is actually registered nurse and Master of Science in her educational background. She has long years of experiences in learning, CPD, pre-certification, and performance improvement. She is a project director for the Gavi project. That project is actually commissioned. This situational multi-country situational analysis on which our webinar is dependent upon. Now I will welcome Julia to take us through this learning session. Julia, the time is yours.
Thank you, Danny. That was a lovely introduction. I appreciate it. It's nice to see some familiar faces and names. As I don't need to do any more of a bio, I think, Danny, thanks for that lovely introduction. Before I pull up my PowerPoint, I just wanted to say I tried to tailor this presentation, mindful that a large proportion of this audience is involved in planning for how to improve health worker learning and performance. And so I've added a little bit more time to go into the process that we use for this situational analysis. I've organized the webinar into 5 different sessions, but let me pull up and I'll get started. Please, we do have, as Danny mentioned, we do have some times for reflection where we will be asking you to chat and contribute. And I apologize, Danny, I forgot to check this with EMA. Is it possible for participants to unmute to contribute during those reflections, or are we using chat only? And I'm sorry that I'm only thinking of this question now.
I think for smooth transition of activities, I think they can put their questions and comments on the chat box, and we can use that along your presentation.
Okay, great. So it says everyone can see my deck now. So as Danny mentioned, he went through my bio, but also I have been the project director for a short-term contract that JPIGO won that was funded by Gavi with support from the Rockefeller Foundation. And this contract ran from March to September 2022 and was really focused on supporting Gavi and other Gavi Alliance members such as WHO, UNICEF, CDC, World Bank, Global Fund, in helping transform how countries and governments invest in efforts to transform health worker learning and performance efforts. So the objectives for our webinar today, which you all should have seen before, is first, I'm going to talk about how we did the situational analysis and some of the key findings. I will spend a little bit of time on what we learned from human-centered design meetings we did in 3 countries with end users. We are going to spend a good chunk of time talking about the evidence. What did we find from the evidence from this situational analysis? I also would like us to talk a little bit, because we are targeting this to professional associations, about the potential expanding role of professional associations and councils in this space globally, and also spend some time and reflection looking at your goals and strategies and how you're looking at supporting improved health worker performance. Those are the objectives for the 90 minutes. Rather than waiting for questions at the end, I do have some reflection times planned, but please go ahead and chat in questions that you have, and Danny is going to help me moderate those. Danny, just a note, because I'm sharing my deck, I can't see the actual chat questions without clicking into the chat window. So after each section, I'll pause for us to be able to either have the reflection activity or discuss those questions. So I'm going to move us on, first talking about why does this matter? Why does thinking thoughtfully around how countries and governments invest in transforming health worker learning and performance matter? First, just a few things by the numbers is the money. As an illustration, in 2018 to 2020, in 2 years alone, the Global Fund invested $510 million in supporting health worker learning and performance. Most of that funding invested in short-term, one-time, traditional in-service training, as well as supportive supervision, even as there's evidence that is pretty clear that the results that we get from that investment are not optimal. So that's just one donor, one illustration. For Gavi, for example, 80% of the funding they spend on human resources for health goes into traditional in-service training and supportive supervision approaches. And so, they commission this work from us to look at, how do we really transform how we invest in health worker learning and performance in a way that countries and donors receive a better return on their investment and better support for health workers. Other numbers for you from one of the studies. You'll see when we get into the evidence, we pulled a lot of the evidence from the landmark health worker provider performance review. That's the systematic review that Alex Rowe, formerly at CDC, formerly at Global Fund, has been leading with support from World Bank, CDC, and others over the last 10 years, looking at all the different interventions to improve health worker learning and performance in low and middle income countries over 40 years. This is from one of the sub-analyses of that work is a finding that the average percent of health worker compliance with recommended protocols and treatment was 37. So we know from that, and also the quality work done by Margaret Crook and others in 2018, that the average compliance is quite low, and a lot of that is really due to the working within broken systems and strengthening systems, not just a lack of health worker knowledge and skills. But you can see it's not where it needs to be. 5, one of the recent results from the Healthcare Provider Performance Review, an article from 2021 that looked at how many of the different learning interventions or strategies, such as in-service training, on-the-job training, blended learning, e-learning. How many of those have actual evidence of effect on practice outcomes over time? And only 5. They were able to find 5 different interventions that had data on effect over time. So for instance, a year after you did the intervention, what effect are you seeing? And we'll talk a little bit about that evidence, but it's concerning that we're investing so much money without really having data on what is the impact over time. And a related number, this comes from the State of the World's Nursing Report. I know this is a webinar funded by the EMA, but it's reassuring to see that the State of the World's Nursing Report found that 68% of countries in the WHO Africa region do have CPD requirements in place, laying a foundation and groundwork for professional associations to play a bigger role in formalizing and providing CPD as an important strategy when it comes to how countries transform learning and performance. So I wanted to share those a little bit to just put in front of you some of why this matters and why Gavi and other Alliance members are interested in changing the way they invest in supporting health worker learning and performance. And I'm not sure, I'm sorry, I don't know, Danny, if you guys are seeing the squiggles on the screen. I have no idea where that came from. Apologies.
Yeah, it is visible, and the audio also is good.
Okay.
But some people actually saying there is no sound. I think it should be from their side.
Let me try. I do like to leave the video on, but let me turn off my video since I'm also sharing my screen, and I don't know if that'll help for them or not, but I'll turn it off for now. So I have this webinar split into 5 sessions. First, I'm going to talk about the situational analysis, how we did it, and the vision, that the shared Alliance member vision that evolved out of that. Then I'm going to get into some more details on what we did for the deep dive countries, in particular what we learned about health worker preferences and learning journeys, because I thought that would be of interest to this audience. Then we're going to look at the evidence summary. Then we're going to move from there to a brief sharing how you can select different approaches depending on the learning goals. And lastly, I won't spend a lot of time on this because Ethiopia already has tools for supporting learning and performance. The Ministry of Health has a CPD platform. I know you're working in partnership with WCA across multiple, I think at least 4 professional associations in Ethiopia for their professional association digital CPD platforms. So you already have existing national solutions, so I won't spend a lot of time on this, but I do want to share that assessment tool. So it's split into those 5 sessions. So first, the situational analysis. So on the screen, you see our scope of work under this contract. And what we're going to focus on today, as I mentioned, is a situational analysis and the findings that resulted from that. So I won't spend a lot of time on this deck, but I do want to reinforce, Gavi asked us to facilitate the development based on situational analysis of a shared Alliance vision. So the vision that I'll share with you later was co-created with representatives that formed the technical advisory group we worked with Gavi, which included representatives from WHO, CDC, UNICEF, World Bank, the Global Fund, and the Bill and Melinda Gates Foundation. So this was our scope of work. It was an 8-month short-term contract. I'm going to talk about the situational analysis methodology we used. And first, I want to be sure we're all on the same page about the context for this analysis. So we decided, partly because of scope and partly because the regulatory environment for professional paid health workers, such as nurses, midwives, clinical officers, etc., is different from the regulatory environment for community health workers. So we focused our situation analysis specifically on, you can see it's highlighted in red, the post-deployment phase of health workers. This is not looking at pre-service education. This is specific to deployed health workers. The target audience for our consultations for the human-centered design meetings We wanted to really reach those involved directly in immunization, obviously, because this is Gavi funded work. So that's their focus of interest. So we focused on mid-level, professional, legally recognized frontline health workers involved in immunization. So clinical officers, nurses, midwives, and other mid-level cadres. And this contract was implemented, as I mentioned, from March to September of 2022. So I want to be sure we're all on the same page. When we talk about the evidence, what we looked at, this is the audience that we focused on for all our discussions. So next, I want to spend a little time on this. So this is the methodology that we used. First, as I mentioned, I already mentioned several times, the organizations that served on our Alliance Working Group. We did a pre-scoping meeting with them where we laid out, this is our plan, this is how we plan to proceed, and got their input. We had periodic engagement with this technical advisory group every month. We had working meetings. So every major product we produced, the inception report, the situational analysis, the vision and strategy document were reviewed and approved by the Alliance Working Group, not just Gavi. So to conduct a situational analysis, we did a desk review, not a thorough systematic review, but we did identify that we would review only literature reviews, meta-analyses, or strategic documents identified by our technical advisory group. So for example, the 2020 WHO Digital Health Guidelines for Health Worker Capacity Building was one of our key documents. The previous, Mott McDonald report that Gavi funded with Gavi supported was one of those documents. So and then from the Alliance Working Group to look at future vision and direction, we also reviewed some of their internal strategic documents. So we reviewed 39 documents looking, and when it comes to the evidence, really focused on systematic literature reviews and meta-analysis. We also did 6 informant interviews with key representatives from national governments. So we selected 2 individuals from the government sector, either someone from the HRHD division or someone from the in-service training division or someone from the National EPI program. And we also did key informant interviews with a representative from each Alliance Working Group member. So during the 16 informant interviews, we focused on the country perspectives on approaches they were interested in, barriers to scale, the future vision that they see. We really wanted to understand, and this was part of the contract, the health worker learning journey and preferences. So what do health workers want? So we did 3 human-centered design meetings, and I'll talk about the countries a little bit later, and reached 59 end users to identify their current learning journey, their experience, facilitators, blockers, and what they wanted in learning and performance, with a focus on digitally supported learning and performance interventions. And as I mentioned, we had regular meetings and consultations with the Alliance Working Group, including a 2-day visioning meeting in Geneva this past June. So I'm going to pause. I see there's a bunch of chats potentially. Danny, is there anything in the chat that you think I need to address right now?
No, actually. I think there are 3 people who raise their hands. I don't know.
Let me, I see that. Let me finish talking about I won't get into the results, just the methodology, and then let's take those questions quickly, and then I'll move on. I did want to put in front of everyone, the countries of analysis. So we selected with Gavi countries where we would do the analysis. These are on the screen. We identified the deep dive countries that are flagged in red are countries where we did 2 interviews at the national level, and we also did the human-centered design meeting with frontline health workers, and we selected countries from different geographies that also had different digital maturity status. So I wanted to share that these are the countries where we did the semi-structured interviews, etc. So before I move to the shared vision, Danny, maybe let's take those 3 questions. I would ask those of you that are asking your questions, oops, sorry. If you could please keep your question to just a minute or two. And Danny, let's take those 3 questions and then I'll respond once I hear those 3 questions. And then we'll get back to the chat on the between the session.
I see two or three people raising their hands. I think Balai and Ima too. Please take the opportunity to ask if you have any question. Or I think
maybe it was raised in error.
Yeah, probably there may be a problem in sound system. I don't know.
Okay, then I'll continue just in the interest of time, and then during the reflection period, if people still have questions, they can ask them, or also feel free to chat in questions in the chat. And then Danny, at the section break, I'll check the chat. I check it now and we'll see if there's anything.
Yeah.
So I wanted to put in front of everyone, I'm not going to spend a lot of time on this, but this is the vision statement that resulted from the situational analysis, ongoing consultations, a visioning meeting with Alliance Working Group members. Looking forward, where do they see the future in transforming health worker learning and performance? And I don't typically read slides, but I will for this. And what was identified was that programs, national programs to support immunization, health worker learning and performance management address individual learning needs and motivations of health workers, irrespective of gender, geography, and cadre, and result in measurable improvements in health outcomes. And then to support that vision, as is often the case.
Julia, excuse me.
Yeah, go ahead.
I think your slide is not.
Oh, sorry. Thank you. I had paused. I thought I restarted. How about now? Are we good?
Yes.
Thanks. Apologies for that. So you can see the vision statement on the screen. I won't spend a lot of time on this, but and I read through it already, but this is the shared vision that the Alliance Working Group agreed to and Gavi is going to start promoting. And potentially more importantly, the guiding principles that underscore and undergird the vision are expressed on the screen, and I will go through these because this is the meat of what the Alliance Working Group felt evolved from the situational analysis and the consultations with country representatives, etc. Of number one importance is that what we do has an impact, that we are investing in efforts that result in impact. When we get to the evidence piece of this, I'll talk about how that can be looked at from the research lens, but I wanted to say this is what really came to the top as being most important in how we move forward. The second is that being country driven, recognizing that countries may need support in particular to transform and integrate digital technology into supporting learning and performance, that really it needs to be country driven, even if say in countries where there's lower digital maturity, they need more direct support than say Ethiopia, which I think is, from my experience, is definitely advanced as far as it being a national priority compared to some other countries in the region.
Julia, can you turn off your video so that?
Sure. I'm sorry, I forgot about that.
Yeah.
How's that? Okay. Then sustainability, that's the other piece, and looking carefully at how things can be sustained over time and making sure that the design and interventions are focused on learner-centric, that we're really looking at how do we reinforce health workers' learning and motivation, recognizing, they need the adequate support and decent system to even be able to achieve what's required in their job. And then lastly, of course, looking at the future, seeing that learning and performance will definitely be digitally supported, which is already happening now, but that's something we definitely see increasing. And again, I won't spend a lot of time on this because I want to focus primarily on the evidence with this audience, but I did want to put the situation analysis in front of you. So Danny, in the chat, are there any, before I shift to get a little bit into a little bit more detail on the deep dive, because I thought you all would find that interesting. Are there any questions that we should address in the chat right now?
I think there is one question on the chat box. It says, is it transferable from Dr. Kabada? It says, it is, I'm not sure I understand the question correctly, but it says can represent the country where low-level administration in rural and disadvantaged area. I think the studies doesn't include the rural and disadvantaged area, and the findings can be transferable or generalizable to those settings. This is the question from Dr. Kabada.
I will say that I would say yes. Some of here we go. Sorry, I just found that question in the chat. I would say that a lot of that was addressed somewhat. So, for example, in the situational analysis, at least in the evidence review, obviously most of those studies are based on professional health workers, but I will say I can't answer the question like whether it was from rural areas or non-rural areas, but we definitely have findings from the situational analysis, and I'll show you where to find everything at the end of this webinar. I have a screenshot of where you can find this on our website. I mean, it's so new, like Gavi hasn't even hosted it on their website yet. But I'll show you where you can find it. But we do have findings and recommendations when it comes to improving access and considering digital maturity levels, which I think speaks to the question about rural and disadvantaged areas. So as far as evidence, the bulk of evidence really is focused on the medical profession, honestly. And so there's definitely a research gap when it comes to looking at digitally supported interventions in particular for other mid-level cadres. So you can get some of that from the situational analysis, but more importantly, when thinking about rural and disadvantages, considering the digital maturity in your selection. And we had produced some guidance documents about how to do that as a result of this. I can show you where you can find that. So I'm going to move on to the findings from the country perspectives. So I won't spend a ton of time on this, but I did think you'd be interested in the details on the learner journey. So you can see a summary of what we did. We had 59 people participating. These were in-person, one-day-long meetings in each country using the same agenda, etc. We had support from TechChange as a contractor to help us design this agenda and train our facilitators, and this was facilitated with support of JPIGO country offices in those countries. The goals of the human-centered design meetings are here on the screen, and I'm going to just jump right into what we found. So on the screen, you can see the learning journey that we mapped based on their input, basically asking them, like, what does the learning journey look like? And we did try to ask our target audience. We wanted people that had, had a range of years of experience from, being recently deployed to, being in the system for a long time. So from graduation and licensure, one of the things that came out is the post-deployment, tends to be a long gap in deployment. In some countries, they seek internships. Otherwise, there's this long gap, which we know leads to delay, a lot of skill loss over that time. Then post-deployment, there's really not a lot that's formal or structured as far as skill-based. I think most countries have some type of orientation, but they did report some type of informal shadowing or on-the-job orientation. When it comes to active practice, what they get to support their learning and performance, you can see on the screen a combination of in-person, in-service training, digital learning, supportive supervision. Some countries have mentorship, but this is what they mapped out for us. And then when it comes to facilitators and blockers, you can see the blockers in red, the facilitators in blue. I don't think these will surprise you, but when it comes to facilitators, obviously connectivity, which I think Ethiopia has done a great job of investing in improving your connectivity. One of the things that is key that came out is protected time for learning. You know, when it comes to e-learning, mentorship, on-the-job training, they still need some type of protected time. That was an important facilitator, and an enabling learning environment, like basically having the time and space to do that. The blockers you can see also, I think, are not surprising. I think one of the things that I thought was interesting is the whole use of paper-based supervision models is not transparent for health workers. So there's that real performance feedback gap. And again, I don't think any of this will be a surprise to you. We did find it interesting to find what they found to be the motivators, and we did ask them to rate these. You know, what do they find most motivating? And so these are listed on the screen. One of the things I think is relevant for this audience and professional associations in general is number 2 is really looking at linking learning to career advancement, or also, you know, CPD. You know, that's an important part in most countries, and I think will only continue to increase to be a primary strategy. But I did want to share these were some of the motivators that came to the top from our frontline health workers. And the other piece I wanted to share, I just pulled this from, you know, as I mentioned, we did the key informant interviews with country representatives from the 7 countries that I showed you earlier. And I did want to share with you and focus primarily on the 3rd bullet, you know, the whole CPD, you know, a piece of this work, so let me back up, a piece of this contract that Gavi funded was focused on the market shaping angle. Like, how do we change the way we invest money and think about the market for improving learning and performance? And that piece is being led by ADP. And we worked closely together on that effort. And I just wanted to flag that one of the things we talked about repeatedly is that the area of continued professional development, you know, especially as more countries more formally link relicensure to CPD credit and CEUs, is going to be a big market driver for learning and performance in the future, probably much more 3 years from now, even from how it is now. And so one of the things that came out of our situational analysis and one of our recommendations is to be more intentional about engaging professional associations and councils in countries to be part of the broader, like, national CPD planning, rather than vertical programs, you know, implementing in-service training independently of professional association goals for their membership. Yeah, I think, and that speaks to the 4th bullet I wanted to highlight for this audience, is especially in middle income countries, you know, in countries, for instance, like Indonesia, Kenya, you know, the council and associations have a much larger role in learning and performance efforts compared to that being driven by the learning and performance, the learning and performance team within the Ministry of Health. So I wanted to put that in front of you, and now I'll pause and take any questions about anything we talked about so far. And Joseph, I see your question. I'll respond to that in a second. And then I also thought, Danny, I would like to hear from maybe 1 or 2 professional association members. I don't know if we have any, you know, midwifery association or nursing association folks on the call, on the webinar, if it's just medical. But I did want to hear, like, currently, you know, when it comes to health worker learning and performance, what role is your association playing? Like, do you provide the CPD? Do you identify the CPD? Do you certify and approve the CPD? Is it that or all? And then also, I'd be curious of your perspective of how do you see that changing for you over the next 3 to 5 years? Like, do you think your association will play a larger role, the same role? So Danny, if we could pause in 1 before we get to the reflection, are there any other questions that people would like to come off mute and ask, or just put in the chat? And Joseph, while we're waiting, sorry, Danny.
Yeah, Joseph has. Yosef has one question about the tool you used for the qualitative methods.
So we did it. We had key informant interview tools that we used for the national stakeholders, and we had a key informant interview tool that we used for a different one for the Alliance Working Group representatives. And then we had an extraction, a pretty typical extraction sheet for our desk review. The key informant interview tools are an appendix on the situational analysis report if you wanted to look at those. So I think I've answered that question. Any other questions before we reflect? I see Shlomo, you have a question. I think Shlomo has a question from USAID, Danny. I don't know if he's able to unmute.
I haven't seen.
Oh, thank you. I was trying to unmute. Thank you, Julia, for excellent presentation. Just I have one question related to financing. Actually, the last bullet says, national with subnational. Governing at central, decentralized responsibilities at subnational level can be challenging. Does it mean like what would be the implication? Does it imply like it should be governed centrally, or what is the take on that? Thank you so much.
Sure. So there were two things that came out, and a lot of this, Shlomo, came from the discussions with the key informed interviews. And one of the limitations is we had 7 countries, right? It was narrow but deep. And Anwar, your question about why it wasn't Ethiopia, we agreed on the countries based on, we had selection criteria based on getting a geographical presence and where JPIGO had country office, participation and availability. So that was the process. We had a selection criteria was used to select those countries. But Shlomo, to speak to your question, there were 2 issues that came up in those interviews, and that I have also seen over my past 22 years of working in this space. The first was just related to the financial logistics of moving money. So for instance, the subnational level will have their plans and they will be formally approved that they're supposed to be running, the trainings that they plan and when they plan them, but actually getting the money released from the central level, which is a problem for them. So that was one of the pieces that came out. And the second was the actual planning and ownership. So you have some countries where it's very decentralized, like Nigeria, for example, which was one of the countries that was part of our analysis, where it's completely independent at the state level. And then you have other countries where, it's still very centrally controlled. So it particularly is challenging in the authority, like if they have the authority at the subnational level, but yet they don't have the fiscal financial means to readily access that money. That was a challenge. Or, there's the formal approval that yes, you can plan and institute your own trainings, but then you'll have the vertical program lead within the central level that is responding to their donor requirements for number of trainings. And so there's that disconnect. So there's a lot of variation, but those were the 2 issues that came up as challenges from our national stakeholders. Any other questions before I will spend Danny?
Yes, Julia.
Go ahead.
I think that Sadaka is asking about in the results of the situational analysis. Is there things related to employers?
Yeah, I see that. That's a great question.
Blockers or facilitators for the learning and performance improvement.
That's a great question, Sadiq. I would say having protected time, like one thing employers can do is provide protected time is a big facilitator. And this was recently reinforced for me during a small JPIGO funded pilot project in Botswana for blended learning for oral prep. we did a human-centered design meeting. We had all these great plans that health workers themselves said, oh, we want to do these practice activities on our own in the workplace, right? They wanted to do it that way. But then the reality was, they didn't have time to do it because they're too busy. So that was, for me, that really brought home, and this was also a finding from our literature review in particular, more than the semi-structured interviews, the number one facilitator is protected time is key, and certainly one of the key motivators is CPD. Like, I keep an active nursing midwifery license because I worked part-time several years ago, and I want to keep that license. So, I mean, to be frank, I do CPD to keep my license because time is busy. So I would say the protected time, and the other thing that came up was the connectivity or covering data. So for instance, making sure if they're accessing digital content or digital learning that they don't have to pay out of pocket. So I think that answers your question. And I see some reflection responses. EMA, I know that you guys play a really active role in CPD provision, and I didn't realize the ophthalmologic society is also doing that. It is fairly common. Are there any other professional association representatives that want to speak to their role before I ask about if you see that changing in the next 3 to 5 years? Like, when you look at your future, what do you see? Yeah, that's true. And just a comment about including CPD related issues. Does anyone else want to comment? Otherwise, Danny, any comments or thoughts? I mean, you're involved, you're in the midst of this right now.
I think our participants are not only from professional associations, they are from hospitals,
Okay.
Universities. So anyone who has, response for this question can, they can personalize to their situation and respond on these questions.
So in the interest of time, because I do think the evidence discussion will take time, I think people want to dig into that on this webinar. So I'm going to shift to that. If people have any additional comments or questions, please go ahead and chat them in. But let's move now to, like, okay, what did we find? And I want to put this in front of you with a caveat that when you look at the evidence on learning and performance globally, honestly, the quality of and really a lot of the work really does come from the healthcare provider performance review, that the review I mentioned earlier, which has produced multiple, studies and had a very rigorous approach. But across the board, the quality of evidence is quite low, and it's not like a medical procedure where you can do a randomized controlled trial. We really need more time series studies or other types of research studies to really identify what has an impact on practice outcomes, not just learning outcomes, because donors and countries don't really care about that anymore, or at least not nearly as much as they care about, does it influence practice outcomes? And I'll talk about that in a minute. But across the board, the quality is low. So I want you to keep that in mind. There's a lot of bias in the studies, and of course, the lit review I mentioned, they controlled for that and they speak to that, but I want to provide that caveat when we look at the evidence. And what we're presenting as far as promising approaches that resulted from the situation analysis also were influenced not only by the evidence, but also by the country and health worker preferences. And I see some comments on the questions in the chat, and I'll respond to those when we pause after this section. So first, to simplify, we have identified, promising approaches, and there was, in this work, to be clear, there was a focus on digitally supported. It wasn't inclusive to that, but that was a big question. There's all these pilots that happened during COVID, and Gavi really wanted to know, like, okay, when it comes to digitally supported, transforming training and supervision, what works and what should we be investing in? So we have organized the approaches that we're going to talk about based on 4 categories, from the weakest evidence, where we have emerging or limiting evidence, moderate evidence, and then strong evidence. But we also categorized these not only by the evidence, but also, as I mentioned, by health worker or stakeholder priorities. So for instance, mobile social learning, which I'll define in a minute, it has very limited evidence. We found one, lit review that Jhpiego, in full disclosure, Jhpiego had done, and some other few studies, there wasn't a lot of evidence, but yet learners like it. They like being able to access content on their phone. That was one of the things that came from our consultations. So things that fell in that category where we said, okay, there's some good evidence for this, and or people also find it a priority. Moderate evidence, that's where we felt like, okay, we feel somewhat more confident in the evidence we found on this particular approach, so we're going to flag it as promising. Or we found some isolated, very promising results, but those haven't been replicated, and or it was a priority. So for example, there's conflicting evidence on e-learning. And when I say e-learning, I'm using the definition from the WHO 2020 Digital Health Guidelines for Health Worker Capacity Building, which is that it is just e-learning. There's no skills component. It's just digital, asynchronous, complete on your own time, e-learning modules. We have some studies that show an impact on provider behaviors, other studies that show it doesn't, but it's very convenient for learners, and it's a critical strategy across the world for providing easy access to continuing professional development opportunities. So we class that as like moderate. And then strong evidence is where, okay, we've got much more evidence, where we can say, okay, we feel like we have more evidence to recommend this approach. There's many caveats to this. This was one situational analysis. We're trying to give Gavi and Alliance members some promising approaches that they can promote and test. We're not saying these are the ways we should move forward, but presenting rather, here are the different levels of evidence and why. So first, I'm not going to read these definitions, but I do want to highlight a couple that are particularly confusing or conflicting in the literature. So on the screen, you see promising approaches that evolve from our discussions or the evidence, organized by approaches where we have more evidence versus moderate evidence versus less evidence. But these are all approaches that we presented back to Gavi and Alliance members as promising. So I want to be clear that one of the challenges in this literature, and I led the literature review we did in 2012 with the Jhpiego team. That was an internally funded effort looking at, when it comes to improving health worker learning and performance, what techniques, frequency, setting, and media are most effective. And consistently now through the last decade that I've been really paying deep attention to this topic, the definitions are problematic. So for example, blended learning, in some settings, blended learning means combining any type of approach. We have defined blended learning consistent with WHO's 2020 guidelines definition, saying that it can include some digital content, but it also includes practice activities. And e-learning, which some people could say, okay, a webinar, you could say is e-learning, but we defined it again, consistent with WHO, as focused on asynchronous self-study, such as e-learning modules on a CPD platform or massive online courses. And then mobile social learning, I'll mention because this was a lit review that Jhpiego did last year that was published in the Journal of Internet Medical Research, I think in August of this year. And that was looking at what many people are doing now, which is basically using mobile technology to provide digital learning, but also includes a social learning component. So not just asynchronous digital content, but there's this component of just-in-time or learner-driven need and support. And I think many of you are doing this already informally using WhatsApp and Telegram. So Jhpiego globally over the last 2 to 3 years has done a lot of this informally, and it's something we're trying to formalize both in how we talk about and how we implement within our country programs. So these are the approaches that came to the top as having the strongest evidence. And before I take questions, and it's fine for you guys, please, everyone, continue to chat in questions you have about the evidence and analysis. But with this audience, I wanted to give you a little bit more detail in what we found about effect size. So the first thing is the healthcare provider performance review I mentioned, which is not the only literature review. I think we had about 20 or so different systematic literature reviews that were part of our desk review. But that is sort of the gold standard and has the most rigorous process and data. But what they looked at was effect size. So because they were looking at all these different studies, and all these different studies measured impact differently, like most just looked at, did they learn or didn't they learn? Some looked at for change in provider practice behaviors or practice outcomes. So the healthcare provider performance review looked at effect size, like how much effect did you get from this intervention? And these are the 5 on the screen. You see the 5 interventions. This is from the 2021 article I mentioned. These are the 5 different interventions, learning or performance approach interventions that have data on effect over time, meaning after a year after nothing was done, what effect do you have? So you can see the weakest is in-service training alone with a 10%. Actually, that's a 10% effect size after completion. After a year, it basically goes back to nothing. Like you've gotten nothing, over after a year. Supervision alone as a 14% effect size. Again, that's in the moment, but over time, it's questionable. The results on supervision alone is questionable. Does it still result in effect size or not? Then in-service training plus supportive supervision together, which receives the largest amount of donor and government money, results in an 18% effect size. Again, that's immediately after the intervention. Then group problem solving plus training. This is like in the human HCPPR, it's the Healthcare Provider Performance Review study. What they call group problem solving is basically any type of QI using PDSA cycles, using process mapping, etc. Combining group problem solving with training results in a 50% effect size, which is our most significant effect size. And that is, again, at time of intervention. And then quality improvement alone, you can see still has a significant effect size, 28%. That is after the intervention. But both of those studies, I'm sorry, someone has access to the annotate and is marking up this screen. I don't know if we can fix that, but apologies for that. It's okay. But for these 5 studies, when the same study looked at effect over time, as I mentioned, for supportive supervision, it was questionable. They couldn't parse out, is there effect over time? Yes or no. In-service training, no, we know that answer. Whereas group problem solving, that effect size continued to increase over time after the intervention. But I will say the author of that study, Alex Rowe, he's very direct, saying when it comes to QI, the data on quality improvement, it looks like great impact, but then the study designs are really weak. So he's like, yes, it shows great impact, but the quality is low. So there's definitely a need for more well-designed studies that can really get to what contextually makes a difference in health worker learning and performance. And then when it comes to, I already spoke to this a little bit, the other things that came as promising, blended learning, mobile social learning, e-learning alone, workplace-based training or on-the-job training, which was one of our preferences from health workers. And maybe it's just because they've experienced it, but they did say that they preferred that type of training. And then mentorship was also one thing that came to the top for them. And again, the definition used in the Healthcare Provider Performance Review was educational outreach, but in most other articles, it's referred to as mentorship. So we used mentorship in our report out to the Alliance Working Group. And then, of course, point of care decision support tools, there's mixed evidence, but providers like them. And there's some evidence showing that they can make a difference in practice outcome behaviors. And I will say that one of the things I really appreciated, let me just back up for a second, about the 2021 study that looked at effect size is instead of just looking at learning outcomes, they actually looked at change in practice outcomes. So either compliance to treatment protocols or reduced consultation time, et cetera. And that is a very rigorous assessment of the impact of an intervention. So I was impressed with that and happy to see it. Please think about the questions you have about the evidence summary. I'm mindful that it's 10:21. We have about 40 minutes left, but we're doing pretty well. I also wanted to share with you, because in-service training continues to receive like most of the money, like what are the recommendations for improvement when it does happen. So again, this came not only from this evidence, but from discussions with stakeholders, but primarily this came from the desk review and the literature review. So number one, if you are doing in-service training, we know from our lit review, in 2012 that didactic, lecture reading alone results in no to low learning outcomes. It's even less when you're really trying to impact provider practice activities. So increasing the time spent in experiential learning and practice. There's multiple studies that show that training that includes clinical practice has a greater impact on skill uptake and performance. And then not only for worker preferences, but also for skill transfer is trying to situate training within the workplace or on the job when and as able. And then because of the evidence, looking at can you combine it with quality improvement approaches or other approaches to increase impact. We did also, I didn't spend a lot of time on this, but we did also look at pay for performance, financial incentives, which is a significant strategy for some of our Alliance Working Group members, for example, the World Bank, but not an intervention for some of our other Alliance Working Group members. So when we looked at, the pay for performance, there's a significant variation. Some studies found, yes, it can really have a quick impact. Some studies found it didn't really have an impact. There are a lot of concerns about sustainability and unintended consequences. And so we did find some very useful guidance on designing carefully for country context, but in general, this did not come to the top as a priority based on our analysis and really based on our Alliance Working Group preferences, but it's definitely an area that's increasing, globally, but there are some important considerations that are listed here for pay for performance. And then there were some very concrete recommendations for strengthening supportive supervision. I think the USAID funded Global HRH 2030 project did a lovely job. I didn't post the link here, but they did a thorough analysis of enhanced supervision and produced a report with some good recommendations. And that was one of the documents, of course, that we reviewed in our literature review. But there's a lot that can be done to strengthen supportive supervision. Integrating mentorship, using data-driven, using data to target your support. I won't spend a lot of time on this with this audience, but I did want to highlight there were some strong suggestions that came out repeatedly. A lot of it centered around really having digital and timely access to data and really using data at the facility level to drive that support and improvement. So I'm going to pause and respond to questions we have in the chat or questions from the audience, and we'll have a brief reflection activity, and then I'll move us on to the next section. So let me check the questions in the chat. Joseph, it is very hard. I will tell you, in the States and in many countries, what they do to deal with CPD is, every health workers. So for instance, in the States, for my midwifery CPD, I submit the CPD, I have to submit a certificate online, but then they randomly audit about 5% of their total audience. So the professional association doesn't individually track or certify every specific individual. That would not be possible, but they use an audit. And if you get audited, and I have been audited, if you get audited and caught for being fraudulent, then of course, you can imagine there's significant penalties. So that is a challenge. Like globally. And Kabebe, I want to just reinforce that it's true there is largely a disconnect between CPD, maybe offered, but like what the challenge really is in the workplace, it's not directly linked. That does tend to be a pervasive issue. Are there any questions from the audience about the evidence synthesis that I just presented before we shift to reflection?
I think there is no question about the evidence, but some people, reflected.
Yeah.
About, CPD is not based on the real problem of the society. And someone also said there is no support from the employers, from the hospitals for the, to undertake CPD. So we should be able to make advocacies. And two people also comment about, CPD should be monitored, should be checked, because especially the CPD accreditation and CEU allocation. Otherwise, there are fraudulent activities, abuses and malpractices. So these are the comments you can reflect.
Yeah, no, those are thanks, Danny. Those are good comments, and I agree, Emmanuel, on your comment about surveying learner members' needs. So, for example, I know for HWIP, we did a baseline assessment of health worker learning needs, and Danny, that assessment and those findings were part of what we discussed when recommending different e-learning courses that we wanted to prioritize. But I agree, identifying those needs is important. And a great example of this is, racial discrimination and racial inequity is a significant impact on maternal health for African-American women in the United States. So for instance, if you're a Black woman in America, you're 4 times more likely to die in childbirth because of systematic racism. And so based on that, members had this request, like, to do better about racial equity. And so this year, during our CPD round of modules we had to do, there was a strong emphasis on racial equity and racial discrimination. So that's a great concrete example of how professional associations can look at doing exactly what you said, Emmanuel, which is a great point. What are the members' needs and how can we provide them with the learning that they need to support it? I would be curious, like, are there particular, like, I went through different strategies or approaches. I know that digital CPD is a significant priority for your members, and you all are actively engaged in that now. Are there other approaches or strategies that your associations want to support? Would anyone like to comment?
Maybe Sadaka has, he put something on the chat. He can, reflect verbally.
You've been called out, Sadeke.
Sadaka. Dr. Sadaka, if you are listening to me, you are muted maybe.
Oh, he's in a noisy place. Okay. That's fine. Okay, thanks for that. So I'll go ahead and move us on because we're at 10:30, but if there are other questions or reflections, please go ahead and put it in the chat. So the next thing I wanted to share with you all, and I won't spend a lot of time on this, is one of the asks from Gavi. They kept saying, well, now what? So if we're not investing so much in in-service training and supportive supervision, what do we invest in and when? And the answer, to be honest, as you all know, is it depends. It really depends on what your learning needs are, how much money you want to spend. If you have a topic that requires intense mentorship, that's very difficult, or if you're just rapidly upscaling an easy update that just needs a performance support tool. So the answer from us was it really depends. And so we mapped out for them some suggested use cases for different approaches that you could select based on different learner needs. So we looked at, globally, like, where are countries and governments investing money, right, in health worker learning and performance? So the first common investment is rapid upskilling. So COVID is a great example. Okay, you have immunizers and you rapidly need all your immunizers to be able to advocate for, educate, and distribute the COVID vaccine. So that's a perfect use case illustration of rapid upskilling. Let's say use case number 2, you have sub-district EPI teams or other vertical teams, and some districts have low performance, or let's say you are supporting a network of facilities in your district. I guess this isn't really a relevant example for this audience, but you want to improve the performance of a health worker or health worker teams over time. So it's more like, okay, in our facility, we're not doing a good enough job with emergency preparedness, and we want to make sure that we address that issue over time. That's our second use case. And then the third is just-in-time decision support. So an example for this would be like here, as a health worker provider, I used to all the time use the CDC STI. There's an STI app, right? It basically says, oh, it's gonorrhea. Okay, here's the treatment protocol. So you don't have to remember, anything. And then there's a cervical cancer app that everybody uses. It's like, okay, based on their age, their history, it's basically a decision tree, right? You put in all the data and it says, okay, then you need to, do HPV, or you need to retest in 3 years, whatever. That's the third use case, the just-in-time decision support. So basically we mapped out, for these different areas, what are different strategies that you can use in pink. So you can see if, say, it's just a knowledge update. All right, you just need everyone to know how to talk about the COVID vaccine. That could be done via e-learning. Or, okay, you need to be sure that all your healthcare workers, can do newborn resuscitation. Say they're transferred into the labor delivery ward, they need to do newborn resuscitation. That's a psychomotor skill, and looking at, on the job workplace, or low dose, high frequency training, such as like the Helping Mothers Survive series, which I think is an excellent example of a quality approach for supporting responding to maternal emergencies, and then using blended learning, digital learning, plus some type of on the job or practice activities. That's one use case. The second is if you do want to improve performance over time. Now, this would be more appropriate, say, within your facility. You have a pervasive problem either with, newborn resuscitation or emergency preparedness or supply chain, and you want to improve performance over time, then you're looking at a longer, slower intervention, and the approaches that have come to the top. Mentorship, of course, supportive supervision. We see collaborative quality improvement as being something with strong evidence, even though the evidence is weak. And many of these approaches are supported with some type of mobile social learning platform, such as WhatsApp or Telegram, that supports that team to improve that performance over time. And Jhpiego has, I think, at least 8 or 10 different projects where we've implemented these type of approaches with some good impact on client outcomes. And then the third use case is pretty straightforward. That's just-in-time performance support. And that may include unstructured advice and mobile social learning, being able to reach someone for help or phone a friend for a clinical case, pretty much anytime, anywhere. So those are the 3 use cases that we presented to Gabi. I wanted to see if anyone had any questions or comments before I move on to our last section.
I think there is one comment. It's about, the cost of CPD.
Yeah.
CPD is, is it cost effective? Is it cost effective for our professionals, for the health facilities or for the health service? And it's read that it is costly. Why not we update our health workers while they are at their workplace? Do you have any, reflection on that?
Yeah, I do. It is a great point. It is expensive. From personal experience, like I'm not in active practice, but I probably spent about $500, over the last several years, which isn't a lot, but over it's not insignificant to do CEUs and maintain my license because I wanted to maintain my license. So it's true that CPD can be expensive, which is why it's very important that at the national or association or council level that your CPD policies and procedures, and this gets back to, I think, I forget his name, Amanel, be linked to actually what health workers want and need, if what's in it for them. If CPD aligns with their area of interest and their needs, then that's important. But it is important to make sure that the CPD requirements are manageable, and that is usually governed by the CPD standard operating procedures or policy, which typically falls under the authority of the professional regulatory body or council. So it's true that it's expensive, and it really should be flexible. So one strategy is, for instance, in many countries, if you act as a formal preceptor in pre-service education for students, you can count that towards your CPD credit without paying. So that is one of the ways that in America, at least, we get midwifery preceptors, because it's an incentive for their CPD that doesn't cost them anything. So it's true that the CPD policy needs to be careful to not overburden health workers, and it needs to align with what their their area of interest is. And it's true in the private sector, it really varies in different countries. Hopefully in the private sector, providers are still regulated and still have to comply with licensure requirements. But it is true that that's a challenge, but most countries, there's that relicensure requirement, and that is the incentive, that aligns with CPD. But again, one of the strategies is making sure that there's a variety of options, for getting CPD that don't cost money. You write an article and get it published, that provides a big chunk of CPD. There should be a range of options, not just formal e-learning countries. And Dr. Sam, I would say that many countries are in the same situation. So for example, I also am supporting Sierra Leone right now, and the Nursing Association just released their CPD policy, and it's a similar situation. Like, health professionals are expected to pay out of pocket to get their courses, that's true, or go to courses funded by the ministry, but a lot of them aren't even getting paid in time. So it really is a challenge, and it's one of the reasons why we see a great opportunity globally for professional associations. If they're more engaged in the in-service training planning, then that can hopefully better align with CPD needs and priorities. And Joseph, this is a great question about digital literacy, which is 100% very important. And I didn't go into this in this presentation, but in the vision statement, I'll show you where that is. We have a graphic that outlines considerations based on digital maturity, because there's different solutions that we looked at that are more appropriate for lower digital literacy, but 100% the digital literacy needs to be considered carefully when it comes to selecting how you want to integrate technology. That did come out of the situational analysis, but I didn't go into that in detail here, but that is critically important. So I'm going to move on. Please continue to chat in any questions. I'm going to move just briefly, as I mentioned, to talk about one of the other components of this contract with Gavi, was that we were asked, so there's all these various digital solutions like Rapid Pro from UNICEF and ComCare, I think from Dtree. AMREF has their own proprietary CPD platform. PSI has HNQIS, Hunkies, they call it, which is a mentorship or supervision platform. There's a variety of digital platforms out there. And what Gavi said to us is, we want a tool that includes quality standards that we can use to assess different digital solutions, so actual different digital technology solutions. Again, I don't think this is super relevant for this audience, but I did want to highlight at least briefly, and then focus on where you can find some of the things I talked about today in case you're interested. So we were asked to create a digital solution tool and then use that tool to assess and report on 10 specific digital solutions. And we had a selection criteria for picking those solutions that we came up with the Alliance Working Group. And the purpose of that assessment tool is listed here, but really it's about helping make sure that countries and donors, in particular countries, can evaluate different digital solutions and think about how well it meets their needs or doesn't meet their needs, and use that tool to assess, to consider the pros and cons of different digital solutions. So again, there's a variety of digital solutions available in Ethiopia, but let's say if you as a facility were, well, I guess you wouldn't do that as a facility, as a professional association, if you didn't have a digital solution for learning and performance, which I think you all do, and you wanted to use this tool, you could do so. I won't spend time on this. This is the process that we use to create the tool, just to show that we did follow something like a modified Delphi process. We went through several rounds of feedback and did use existing existing tools. But basically, we have the tool organized and standards that support the themes that undergird the new vision. So standards that help assess, is this tool impactful? Is it country driven? Is it sustainable? Is it learner centric? And does it align with the digital strategy? So the tool can be used, and this would be used more at the in-service training, HRHD or National EPI Program Manager level than at the professional association level, but it can be used then to assess a different digital solution. And then the report has, for our 10 different solutions, it sort of maps like, how does this solution do for each component of the vision? Is it really strong in being country driven, but yet it's not that impactful? Is it very impactful, but not as country driven? And so the solution tool can be used to consider the different pros and cons in various solutions. Oh, again, for this audience, I don't see you needing to use the tool or the report, but I just wanted to flag it because that was a key component of our contract. So I'm going to pause and perfect. I want to leave time for questions. I'm going to just check the chat and see if people have questions, then I'll explain how to find a lot of these assets in case you need. I see a lot of chat about CPD is not CPD Center, but Business Center. It's just can be true. And it's the same thing can be said. I see the same thing in accreditation. Like, for instance, I think I was talking to someone who runs a university in Nigeria, and he was saying, he pays all these different accreditation fees to like 5 different agencies. So it is really important that at the national level, the CPD procedure does not create undue burden on health workers. And also, like, that CPD is used to incentivize the behaviors that you want. Like, so for example, if you're getting your master's, then that counts towards your CPD. You don't have to like do other courses, right? If you work as a preceptor and you mentor students, that counts towards your CPD. And there's a process in place and a form for you to report that. So there's ways that countries can use CPD to really advance their priorities and objectives. And I will comment the role for a centralized CME portfolio. I think that's the idea behind. So for instance, in Ethiopia, like EMA, I know you guys have your CPD platform that you are doing in partnership with the World Continuing Education Alliance, and ENA has one, EMA, EAA. That's the same situation in Kenya. Each association has their own digital CPD platform, and that sort of serves at least as a central repository for learning opportunities. Also, the website can link to non-digital opportunities such as in-person conferences or providing guidance on getting CPD approval for journal credits, etc. And also GetsNet, I just want to reinforce that yes, CPD is part of protecting the public, and sometimes it falls, usually the association may provide CPD, but the council is responsible for certifying it or approving it. I do want to highlight for everyone, mindful we have about 15 minutes left in the call, and I do think, Danny, I need to leave 5 minutes for the assessment at the end, right?
Yeah, yeah.
Okay. I just wanted to highlight where you can find, if you're interested in any of these resources or assets, if you go to the jpygo.org open website and you click on resources, we have a technical resources section. It's a little bit, it's not a very user-friendly, I'm sorry, like site, but if you go to technical resources and you look at, and you can click the home button, if you search for learning performance and technical documentation, we have arranged all the assets from the Gavi work that are available for you if you want to see them. And I highlighted the two that I think you might find most interesting. If your time is limited, the first one highlighted here, I pulled from our situational analysis just the evidence summary. So if it doesn't include all the links to the resources, but if you just want to read the summary of the evidence, you can look at that document. It's like 8 pages. If you really want to dig into the detailed, like 60-page report or 30-page, I think we did better without appendices, then that is the full situational analysis. The quality standards score sheet is the assessment tool that I mentioned. I don't see you needing that. And I forget, someone mentioned the question of digital maturity. The vision and strategy document, the second from the bottom, that's the one that has the table with different considerations for digital maturity in case you're interested in that. So I think, let me turn on my video again. Does anyone have any other questions or comments? And I want to thank everyone for being really active in the chat. Really appreciate that. Oh, thank you, Ahmed. Appreciate that. Any questions or comments from anyone? Looks like no.
Maybe I would like to add, some people are, there are some resentments about the CPD activities in Ethiopia. Yeah, we are actually starting, CPD initiatives. We are, new. So obviously there should be, some hiccups. So I think we are developing a system, and in the meantime, after some time it will be improved. So we acknowledge your comments here, your resentments, and Ministry of Health, FM HACA, regional health bureaus, and the associations and other CPD providers will consider, and we also support, to improve, the CPD implementation in the country. And you can also use other, like, this kind of, CPD activities, so that, your credit hours for the relicense will be achieved. That's what I would like to add, Julia.
Thanks, Danny. I'm glad that you guys are supporting that. I know that that's an area that TEGBAR has done also, and your team has done a lot of work in thinking. In particular, I know TEGBAR has also had, many conversations, been passionate about CPD being meaningful, which links back to someone's comments earlier. I think Emmanuel's making sure that it's meaningful, not just checking boxes and making money, but an important part. And I do see, like, I'm not speaking at all about the market shaping work, but looking at the future, it is an important part of the market and how countries invest. And I do hope to see a future where associations and councils have a more direct role in that, and it's not so much driven by the vertical programs at the central level. So anyway, thank you everyone for your very nice thank yous. I really appreciate that. It makes my morning. It's lovely to I see some names I know too, which is nice. Okay. Damtao, I think you may have missed my comment in the beginning about the caveat about the weakness, the challenges of the evidence around in-service training, because it works within a messy system and a lot of the evidence is not, a lot of the studies are not well designed, and it's not like a medical trial, right, where you can do a randomized controlled trial. And there's some recommendations in the situational analysis report about how we can do that, but more interrupted time series studies is one of the recommendations come out, and really putting more effort into considering contextual factors that make a difference in outcomes are really important. There's a couple of questions about sharing the slides. Danny, I assume that SAMI or EMA can do that with their members.
Yeah, we can do. We have another copy and we can share.
Okay, I think everyone has to do their quiz now before they leave. Yeah.
Yes.
Okay.
Yes, sure.
Okay.
Sami, can you tell
There it
us how our participants would take the assessment? Sami. Okay, I think it's a the post-test quiz is put on the the chat box. Before you leave, you have to complete it and send to the Ethiopian Medical Association. And upon submission, you'll be granted 1.5 credit hour for this webinar. So thank you so much, everyone, for your time, for your active participation, and thank you, Julia, for your time again, for your unreserved efforts and resources. It's much appreciated. And also thank our association, the Ethiopia Medical Association, for creating such learning platform. I think it's time to conclude our webinar. Happy Ethiopian Christmas for those who are celebrating.
Awesome. Thank you. Thanks to EMA. Thank you for allowing me to join you. This was really fun. I appreciate it.
Thank you.
Thanks. I'll hang on. I'm just going to hang on, Danny, in case other people chat in questions until it ends at 11. Thanks.
Okay. Thank you.